Well, hey everyone, it's Dr. Adam Brown here with my co-host Dr. Lara Zibners, and this is another episode of Unstable Vitals. And healthcare is unstable, and Laura, so are
So are
we.
we. So are
Yeah, we're unstable too. So it's so good to be here today with my good friend, Dr. Jocelyn Wittstein. She is a former medical student colleague of mine. We were together in medical school back in just a couple of years ago. We won't tell you how many years ago, but it's so
we.
good to have her. Yeah, yeah. We're not going to mention the actual years, but
It was still younger than me, so I'll just throw that out there. I'm guessing you graduated after 1997?
Not long.
not too long after that. Not too long after that. But the reason why we wanted Jocelyn on today is because Jocelyn is an orthopedic surgeon. She's a sports medicine specialist at Duke University. We won't hold that against her, having the fact that Laura and I both went to UNC. But whatever, we'll gloss over that. But to really talk about women's orthopedic issues and also some of the other issues that are surrounding women's health as women get older, and of course men's health too, but how there's not been a focus there, and that is one of the things that is making our healthcare system unstable. And so we're excited to have you on, and we say the healthcare system unstable, but people's bodies unstable, people's health unstable. So we're really excited to have you on, Jocelyn. Thank you so much for joining.
Yeah, thanks for having me, and nice to meet you, Laura.
It's so nice to meet you. I mean,
you.
a book author and everything. I've got my own copy. I'm super excited to dig in today.
Yes, we've got our copy here. So, Jocelyn is an author. Bone and Joint Health Plan just came out. When did it come out, Jocelyn?
In May.
Yeah, so it's not been long. I know that we've seen you on the circuit, speaking about it, doing videos and things like that on Instagram, also doing some book signings. I was very excited to receive my copy. You can get that on Amazon. I think you can get it at Barnes & Noble. Is that correct as well?
Yep.
I mean, I had to pay for my copy, just saying.
I'm sorry. Adam did not ask me to send 2 copies.
Sounds like Adam.
I know.
But I was pleased to see it's hefty, but it's not so hefty that it's going to affect my bone density in any sort of positive way. But, very exciting.
But yeah, I mean, just jumping in here, we oftentimes, I mean, in medical school, I don't remember, and even especially in residency, in emergency medicine residency, we didn't talk a lot about bone and joint health. I mean, we talked about it in the context of, oops, I slipped and fell and broke my arm, and then the acute care sort of aspect. But we didn't talk about bone and joint health as a preventative focus, as a sustaining type of focus. So why are you interested in this space beyond bone broke, bone fix kind of philosophy of orthopedics?
Yeah, I mean, I am a full-time orthopedic surgeon. I work with residents. I work with fellows. I also do research. But the book was sort of just this side passion project, like something I wanted to work on, basically nights and weekends. I think that many people have a basic lack of understanding of their bones and joints. They don't have a good user manual for that. And, the overwhelming amount of disability that people face as adults is related to lack of mobility, which is related to arthritis, which is a huge cause of disability in adults. And then, many people sustain fractures as they get older and become more frail, which really kind of leads to a further decline in their function. So, we think there's a lot of, jokes made about orthopedic surgeons and how they just want to fix broken bones and things like that. But
I would never say something
I've
like
never
that.
told a joke about an
Never.
orthopedic
Yeah,
surgeon.
yeah.
Never.
Like the jokes about asystole, but we still need to fix the fracture, that kind of thing. But in reality, bones are incredibly important, aside from, supporting our skeleton and being the origins and insertions of our, muscles and tendons and things like that. But they're like major endocrine organs, essentially, in our body. They're the storage for calcium, which has other major jobs, like allowing our muscles and our heart to work, and our brains. So it's there's so much more than structure. And the other thing is, not only do patients or people in general not understand the silent disease that osteoporosis is. They don't understand nutrition, which can help them, not develop osteoporosis. People don't understand what kinds of exercise to do. So I think, especially with something like osteoporosis, which is silent until you break a bone, more or less, it's silent until it's a problem. And then once it's a problem you can't get rid of very easily. I think something like that, people just need, more information about. Arthritis is a more obvious problem to people. People start to experience pain, swelling, things like that. And people are hungry, really wanting good, real advice that is evidence-based, not, the supplement world is crazy. There's so much bad information out there. And so I think people are more aware of problems with their joints, but the very big, large problem that people need to be proactive about, that they don't know they need to be proactive about, is the health of their bones. So preventing osteoporosis, and especially women who are much more prone to this.
I think you just hit on something I was thinking when you were saying that is, when I was younger, my mom would have all these bottles of glucosamine and chondroitin, and I'd be like, that stuff doesn't, I don't know why you're, and then, as I got older, I was like, okay, desperate, stabbing around in the dark, and I'm going to take it, and it does nothing. And I'm at a point now where I have to sit down to put my underwear on, and I don't want to get any worse than that. So what do I do?
Yeah. So glucosamine chondroitin, that is one of those supplements that is heavily, heavily marketed. And if you look at the data on it, like there was something called the GATE study where people were, randomized to that or other options, and it basically didn't pan out. That's probably the best done study on glucosamine chondroitin. Didn't make a difference. There was some subgroup in people that had more severe arthritis where they had some benefit, but in general, that is not a supplement I recommend to people. I always tell people it'll cost you about $30 a month. It's fine with me if you want to take it. It's not going to hurt you. If you get some placebo benefit from it, that is fine. The only thing it's hurting is your wallet, $30 a month. But anyone who's like a true believer in glucosamine chondroitin, I tell them take it for a month, stop taking it for a month, and just see if you notice a difference. Because if you don't notice a difference, you don't need
That's
to.
That's a good way to think about it, actually.
Yeah.
Because, you're right. Like, there could be some placebo effect, and someone says, okay, hey, this is great for me, and makes them happy. But, I think that's a really good point. Fun fact, as I think you both know, I have a Great Dane, and veterinarians are trying to pump glucosamine and chondroitin for my dog to protect his arthritis as well. So it's made its way into other fields.
Yeah, I don't know the data on dogs, but and back to your problem with putting your underwear on. People actually fall that way because that's like a pretty common mechanism. They're trying to get this second foot in, and it gets caught, and then they fall. And so I do talk to people a lot about just practicing single leg balance.
I was just going to stop wearing underwear.
Yeah, or you could do that. Yeah.
It's a choice. It's definitely an option there.
I think it's a valid choice, right?
It's a valid
shared
choice.
decision making. Yeah. That's your option. Yeah.
While I still can.
Yeah.
Right. But as I one of the things I've learned, especially working with you, Laura, working more with women's health companies, also digging into nutrition and mobility and teaching spin class and that sort of thing, is really how much we have focused as a healthcare, as a system and as a medical system on cardiovascular health, on stroke health, but we have missed kind of the antecedents to those things. Like you hear people talk about, exercise, nutrition, but there's not that connection really made to really bone health, mobility, the ability to function and do those activities of daily living and do it well are connected then to cardiovascular health and connected to stroke health. Yes, there are people that have sudden cardiac disease and boom, they're done. And there's no mobility thing kind of ahead of that, and people die sometimes at a young age like that. But I'm talking more about the people who have an injury that could have potentially been prevented because of mobility or flexibility or stability balance. They've fallen. Now they've injured themselves. Now they've become more frail. They can't get up, and now they can't exercise, and now they start having decline, and now they develop stroke, diabetes, healthcare, whatever, heart disease. And I feel like we kind of jumped to the end in our normal American healthcare system of let's fix the disease and not prevent the thing from happening in the first place. I mean, what are your thoughts on that?
Who, me or Laura?
Yeah, Jocelyn, I'm sorry.
Good
Yeah.
part one here.
So I think there are two major problems in our healthcare system in general. One is we're not proactive, we're not prophylactic enough, we're not preventative enough, and the other is we're too siloed. So, and the things that we can prevent require being more preventative, more proactive, and being more connected across specialties. So, you know, the classic example is hip fractures in women. So there are two stories here. Menopausal hormone therapy is FDA approved for the prevention of osteoporosis, and it prevents 30% of hip fractures. It prevents 40% of vertebral, insufficiency fractures, reduces all-cause mortality by 30%. So we have our OB-GYNs, we have our orthopedic surgeons, which are 94% men who will never experience menopause. And I love my partners. I do. They're my very good friends, but it's just, not part of their own life experience, right? So women go through menopause. In general, people lose kind of 1% of their bone density per year after the age of 30, but when you get to menopause, that accelerates something like 2%. Women lose about 20% of their bone mineral density in the first decade after menopause. Women get 75% of osteoporotic hip fractures. 1 in 3 women, has an osteoporotic hip fracture in their lifetime. So we have this known entity that is very safe for most people, that is highly effective at preventing a problem, that is treated by another specialty who sees the problem at the end when the fracture occurs. Now you have an older woman who has poor bone density who falls and breaks a hip. And we're treating, the back end of it. If it were more, commonly indicated, if hormone therapy were more commonly used, for instance, for preventing osteoporosis, we would have less hip fractures. Now let's look at another, cross-specialty issue where we're too siloed. Okay, so now you have an older woman who breaks a hip. Why did she break her hip? Maybe she had a UTI and she was disoriented in the middle of the night and fell. Maybe she didn't have a UTI. Maybe she just had a hip fracture. But what is the number one complication of hip fracture surgery? It's UTIs. Okay, how do you prevent UTIs? With vaginal estrogen. But who prescribes vaginal estrogen? Urology, women's health. Is this something orthopedic surgeons provide?
Can you imagine the look on orthopedic? I can just imagine ordering vaginal estrogen in an orthopedic patient's chart and having the orthopedic resident look at me like I had horns, right? I would never think to do that.
I've been talking to my trauma partners about that, and they were like, well, how is this applied?
Vaginally.
And
into the vagina.
They're seriously interested. And you know what else? There was a study recently, like the Step High trial, which is this randomized trial where women got testosterone after hip fracture surgery and combined with therapeutic exercise, and they didn't show any difference in terms of 6-minute walking distance for people who had the post-operative exercise program versus the exercise program plus testosterone, supplemented at female levels. But the testosterone group had half the risk of needing a cane or a walker 24 weeks after their hip fracture was fixed. So my point is that we have these conditions that are preventable, that we don't, as a medical system, do a good job preventing. Then when they happen, there are other, like in the case of women, hormonally related interventions that can reduce some of the known problems and complications of the condition. Like if the number one complication of a hip fracture or OIF is a UTI, and one of the main, declines we see in function is, like if you break a hip and you weren't using a walker, you're probably going to need a walker. If you were using a walker, you're probably going to need a wheelchair. If you were using a wheelchair, you're probably not going to transfer anymore. People tend to decline a level. People who break hips, like at, a year after their hip fracture is fixed, something like 60% of them still are requiring assistance, right? So these are, but these are things that if we work across specialties can be, probably significantly diminished.
But
Can I ask?
you go ahead.
Sorry,
Laura.
I was just going to ask a question. Is the reason for that because of, the frailty issue is kind of a combination? So we want to prevent osteoporosis, but then we also want to prevent sarcopenia, right? Is that part of the, or do you consider those two different things, or do you consider that all part of the same?
I mean, I think of frailty, again, I always like to think non-siloed. I mean, we have cognitive issues, we have cardiovascular issues, and a lot of them are musculoskeletal. Mobility, grip strength is one of the markers of frailty. These. So yeah, I mean, we develop sarcopenia as we get older. Mobility is affected by, our balance, our muscle mass, our agility, our resilience to falls is dependent upon our bone density and risk of fracture. So interestingly, like so much of our independence and mobility is orthopedic and musculoskeletal, related truly. But we can't be functional also if we don't have, a good cardiovascular system and if we don't have good cognition. So, but the beauty of this all is there are so many recommendations that have a lot of overlap. Like one of the few things that actually is protective against dementia is 150 minutes of exercise a week.
Right.
But that is also important for your cardiovascular health. I follow the cardiovascular teachings of Dr. Benjamin Levine. I love his work and his research on getting in a HIIT day, getting in an endurance day, and then a few zone tune days. And but then you think, okay, well, we also need to do certain things for our musculoskeletal and orthopedic health. Like, what do we need to do? What is proven to improve our bone density? Strength training, heavier if you can, a few days a week, but also some impact exercises. And so we don't have 1 million hours a week. So I tell people okay, if you're going to do some of your impact exercise, work those into your HIIT or whatever, but we need to wed all these things together. And we've got cardiovascular recommendations. We've got recommendations for bone density. And I try to kind of blend them together.
2 points off of this. You can see how patients could be easily confused. I mean, even myself. I mean, I'm a doctor, and when patients or friends or colleagues ask me, well, what should I do? I mean, there are different schools of thought, and I think at the 150 minutes in a week is something that I tell people a lot, and I think, as I've told you before, both of you, I'm studying for lifestyle medicine boards, and that's something around nutrition and exercise and stress reduction and is very important, and that linkage between the ability to live long and healthy and avoid some of these other major issues by continuing exercise. But the second point though is that you can see how this confusion is oftentimes brought on by our own specialties. I mean, you brought up such a great point of orthopedics is mostly focused on doing the surgery after the acute injury has happened. Urology is focused on another area. Cardiology, for example, I mean, think about after the old WHI study, they're focused, oh my God, we don't want any cardiovascular disease whatsoever. We don't want any blood clots. So therefore let's get rid of all hormone therapy, totally avoiding kind of the small number percentage that there was an incidence of an increase. But the bigger piece of oh, well, if we had given estrogen, if we had allowed women to have hormones, they would have a greater, more functional life, lower instances of depression, improved, all these other
actually better lipid panels and
exactly
less risk of cardiovascular disease. Yeah, I mean, of course, the original flaw in that study was, incorporating women who were more than a decade out from menopause, and also, using Premarin, which is not what is used today, but that was what was,
But that's an example of one group saw that, oh my gosh, there's an increased incidence of this, that, and the other, and kind of avoided thinking about all of the other components that make us a human, all the other pieces of who we are. So is that the reason? So this is the question after the comment. Is that kind of the reason that through your practice over the last couple of decades, has that been the reason why you said, okay, I want to write a book on this, to kind of pull it all together, to make it simple for people to understand?
Yeah. Yes. And you can't make things, I mean, this from interactions with patients. If you're not like truly in the medical profession. Sometimes things need to just be, you have to break it down or make things like bite-sized or digestible or something that people can retain. Like, I don't want to break it down to just too simple, like too much of a takeaway point, but I tried to give people not too much information, but enough information that sort of justifies the thought process for them, like evidence, but not too much, not like a meta-analysis.
Right.
I'm basically summarizing a meta-analysis, but yeah, I mean, I wanted people to have good information, and there are various parts throughout this book where I, reference things that affect women's health or your cardiovascular health or things like that, and I do try to see people as a whole person, and not just a bone or joint.
And you're not going to say the heart's just there to pump the blood to the bones. I thought
No,
that's
it's not just there to circulate and stuff.
So
Yeah.
back to the confusion part, because I thought Adam's easily confused, and I thought he was still back at how you apply vaginal estrogen. But I think he summed it up pretty
I don't
well.
deal with a lot of vaginas, as you know.
Yeah.
So.
Well, I run a vaginal drug delivery company, so I feel like I'm a pretty credible source of information on how you do this. But if you want to talk about that offline, Adam, we can go through it. Anyway, I think there's also a lot of confusion because you include a lot of nutrition, a lot of anti-inflammation, and this is where I think there's been a big issue with women's health, which is really societal health, because every man has known a woman, at least one in his life. But because women's health has now been blended into women's wellness, like there's a really blurry line between the supplement world and the jade vagina egg world and women's health as a scientific thing. And so when you talk so much about nutrition, what were your thoughts about that and how you thought to include that?
Yeah, well, I mean, I think nutrition is a major basis, for health in general. I do try not to recommend like too many supplements to people. I think there are certain supplements that have such good evidence behind them and certain things that are just really hard to get in your diet that I want people to know about and be aware of. I do think there's so much money circulating around telling people what they need to do for themselves. Like, you have to buy this piece of exercise equipment. You need to use like this supplement and like this special creatine, which is not any different than like, things for women. I mean, but this is old as time, like women's Motrin for menstrual
Like the pink
cramps.
tax.
It was just Motrin. It was just
Yeah. Mm-hmm.
So, there's so much marketing to women, and I don't, I don't have like an Amazon storefront or something like that. Actually, I have people ask me like, oh, what supplement do you use? And I'm always afraid to actually tell someone like a certain specific brand or something. I don't want them to think that, like this is the only thing that you can buy or use.
But that's what I just was going to ask you, because the supplement industry is unregulated, and we read all this stuff, well, it's not really what's in there. So, I was amazed to see that you recommend collagen supplementation, different types for different subgroups of patients.
So, I do try to give people pretty clear advice about what is evidence-based in terms of collagen. So, there are collagen supplements often have a mixture of types of collagen in them, but, you want to look for something specifically for bone density. I did actually mention a brand in the book because it was very well studied in a well done prospective study called Fortabone, which is a hydrolyzed type 1 collagen. Type 1 collagen is in your bones. You may remember when you were studying in medical school, bone has the word 1 in it, so type 1 collagen is in bones.
I never learned that.
Oh,
Thank you.
well,
Changing
yeah.
my whole world.
I should have studied more with you. I think we studied some things
I
together.
mean, I'm a
but, like,
pediatrician. They're just made of cartilage. They bounce.
Yeah. Anyway, the study of Fortabone, which is a hydrolyzed type 1 collagen, 5 grams per day, was done on menopausal women with low bone density, and they showed, impressive improvements in their vertebral and hip bone mineral density at 1 and actually 4 years. They did like a follow-up study. And so, I use that. I do recommend it to people. I think that And then if it's something that you want to do combined with hormone therapy, at the time or leading up to menopause, will help you preserve your bone mineral density. And I mix my collagen into my coffee or smoothie every day. It's super easy and dissolves, and you don't even know it's in there. The other, type of hydrolyzed collagen, of course, hydrolyzed just means broken down, right? And you digest it, is if a supplement that contains hydrolyzed type 2 collagen. Type 2 collagen is the type that's in our joint surfaces. So, we think about bones and joints for our mobility and, musculoskeletal health. And so there are studies, even a meta-analysis of well-done studies, showing that 5 grams of hydrolyzed type 2 collagen per day reduces symptoms of joint arthritis. There isn't proof that it slows progression of arthritis, but reduces symptoms. And then there's a type of collagen that is, you might see it on shelves called like UC2, like undenatured collagen, so, but type 2, so it says UC2. And this is obviously a much smaller dose. Instead of it being 5 grams, it's like 40 milligrams. And undenatured is something that you're not going to absorb. But the studies on this show that there's essentially, and being in pediatrics, this will be familiar to you, like the concept of oral tolerance, that your gastrointestinal tract is exposed to this undenatured type 2 collagen, kind of recognizes it, and then there are studies showing decreased breakdown products of articular cartilage in people that take the 40 milligrams a day of undenatured type 2 collagen, so UC2. So I tell patients, like, you don't want to take a million things and buy a million things and be trying all these things. So I tell them, like, try one thing at a time. I think I hear a thunderstorm behind you. Yeah.
I am in the mountains, and we have been struck by lightning on several occasions because
So-
God is angry at me, I guess.
Yeah.
Anyway,
So anyway,
I have no idea why.
Yeah.
so no idea. I didn't do it.
if someone is like, oh, I'm not going to do that powder, that's just too much for me, I don't want to think about putting up my coffee or my smoothie or whatever, you can do just the little 40 milligrams of UC2 a day. And they work by different mechanisms. If you wanted to, you could do both. But I use a collagen supplement that has type 1 and 2 hydrolyzed collagen in it. I just put it in my coffee. So,
Okay. That's
So
going to
I-
be added to my coffee.
So I wanted to kind of go back in time a little bit. I think one of the issues that Laura and I have discussed on our podcast before, and just over wine or coffee, has been about the lack of women in certain fields in medicine, and then how that becomes kind of an antecedent to longer term type of issues as a society and as a human race. I remember very vividly back when I first met you. I think you went to Cornell, right? And you were there at ECU, and we were talking, and you had an interest in nutrition and those sort of things. And I remember you saying, like, you were going to orthopedics, and I immediately was like, whoa, this didn't match the look that I was thinking of someone. I mean, I won't say how tall you were. I won't say, but you're not a massive individual, I mean, when you normally see the orthopedic surgeons, they're usually big, burly guys that are kind of walking in. And you had said something earlier that I think women are only 6% of the specialty of orthopedics.
yeah.
Tell me, number one, how and why you decided to go into orthopedics. That's kind of the first piece. And then the second is, were you received into the specialty? And probably moving into that, a 3-part question has that been an advantage in some cases to talk about issues like this, or a disadvantage in some cases?
Yeah, you are correct. The field is 94% men. There are growing numbers, and there's a great publication. I don't have it on the tip of my tongue, but it showed, like, in order for the field of orthopedics to, like, equalize with the population, it's the number of years based on projected growth is it's like 252 years or something.
Wow.
I didn't realize we'd talk about this today, so I didn't reread the study, but it's an amazing study. I'll send it to you. It's just, I've seen it presented in different places, you know, on PowerPoint slides or whatever. And every time I see it, it's almost like a funny joke, but it's real. So, right, there is growth. We have higher numbers in residency, but we have got 6% of practicing orthopedic surgeons are women. And I, I actually didn't realize that when I was applying to orthopedic surgery. I was very naive. That was what I wanted to do. It was what I was interested in. I probably should have noticed on visiting rotations that there weren't a lot of women around. But
your personality is an unbothered personality.
I'm
You're
not
like,
really
I'm just doing what I'm doing, and like I'm just gonna do what I do. And it's
I love people of all types. I have gay friends. I have friends of all cultural backgrounds. I have tons of friends that are men, women. You know, so I think I went on these. You know, I did my away rotations. I didn't really think of myself as being a minority in the field, but I also worked really hard. And to be honest, I crushed my. You know, I had like 99th percentile and everything. It wasn't like I was like
I remember
bad applicant or something. And I was really excited to go into this field, and I felt that I matched into my number one place. I went to Duke, and I felt really welcome there, and wanted as a member of the team, which was great. The funny thing that happened to me, which really I think threw everyone for a loop, and I didn't realize it would be so unusual to people, was I also decided to have babies during residency, and I had my first child as a second year, and I had another child as a fourth year resident, and I'm never going to forget the day, bless his heart, as we say, that I had to tell my chairman I was pregnant when I was an intern. And that was the point where I was like, okay, I'm different than everybody else.
I think that's amazing, because having a baby during residency, no matter what your specialty, is a pretty daunting feat. But your description of being warm and welcome, I listening to you, I'm having flashbacks to my orthopedic rotation when I was a pediatric EM fellow, and I was treated so poorly by this all-male team that I was determined to show my worth. And one night, putting bones back together is a lot of physics. It's not, men would like us to think it's brute force, but it's just about using your wits and bending the bone.
Well, you have to use lever arms and things like that.
That's right. And so I was trying to put a bone back together before my resident got to the hospital, and I was like determined to make this happen. And by the time he got there, because he was like, fine, get started. By the time he got there, the kid was sitting there with a molded cast and a perfectly done fiberglass with an ice lolly, and I'd left the X-ray machine thingy-mabobber in the room with the image up, and he walked in and he said, Jesus, you really know how to emasculate a man, Zibners. And he walked back out.
That's funny. Well, I think, but yeah, so there were some doubters, from time to time, like when I was then a pregnant intern, and I didn't miss, any days of work or anything, and I reduced fractures and dislocated shoulders and whatever when I was super pregnant, and, but I had there were a couple of people along the way who doubted, once I was pregnant, maybe doubted my dedication to my field, or that I would be able to do it, or told me I would fail. These were people in the minority, but those voices are disconcerting and loud. And this very small number of people who said those things to me, didn't actually say them to me. They wrote them in evaluations. And I made a point to go meet with them and talk to them about it. And I just said, why did you say those things about me? And they really couldn't give an answer. And I was like, I think it's just because, I'm a pregnant lady. and in the end, everything worked out fine. Both of my kids, I was at work until the day I had them, and I came back 6 weeks later, and I made up everything. I didn't miss anything, and I did well. And but it's funny, on the backside of that, then it's like, wow, you did that. And I felt lifted up again, I guess. And the small number of people who doubted me didn't doubt me anymore. And I am a mom. I'm a full-time surgeon. Do my kids want to be doctors? No, they think it's insane.
My dad's a doctor, and I was never going to be a doctor because that was insane. And then all my friends were studying for the MCATs, and I'm like, oh, I don't want
Yeah.
to be alone on Tuesday. And here I am. Going back to what you were saying, though,
Oh,
I
right.
think
Yeah.
this whole concept that there's so much bias against women in medicine, and I have to remind myself when I see an airline pilot who's a woman or a surgeon who's a woman, like they had to be better. Often we had to be better than, right? Did you feel that pressure, or were you just naturally brilliant and landed at the top?
I felt the pressure of I didn't want to let anyone down who came after me, that maybe wanted to be an orthopedic surgeon and was a woman and maybe wanted to have kids. That was more the pressure I felt, that I wanted to make sure that I was a really good example, or I made everyone feel reassured that this could be done successfully, because I thought if someone else came behind me and I didn't do a good job at this, it would be harder for them.
But that's a thing that minority communities do face. This whole notion of feeling this responsibility to be the best, the top, because they don't want to let down either people around them or people that come behind them. I just want to say as an aside, and I'm going to use this term very, very purposefully, it is fucked up for a supervisor, someone to write very specifically about you being pregnant and not being dedicated. That is an HR major woo woo. Like,
Well,
I mean,
think
having been in the corporate world
yeah.
now, that shit would be a big
Yeah,
round.
I one time someone said to me, unless you are superhuman, you will fail. And I was just like, okay, well, I don't golf, I don't watch TV, I work out every day, and I do my work, and I have my family, and so these are bad apple examples. I have so many wonderfully.
Yeah.
I went through my training with so many incredibly supportive people, mostly men, because the field is mostly men, who are my mentors, and he for she, and women who had my also support me. But it's like having a couple of people detract from that, it does kind of
Even okay, let's say devil's advocate, that person was trying to help you understand the demands of a career in surgery and balancing.
100% thought they were
Right?
helping me understand that.
Right. So, but even if that was true, wouldn't that be a systems problem?
Well,
Yeah.
they thought they were letting me know this was going to be really bad. I
But
guess.
parenting to start with is really bad. Like, I'm a pediatrician. It turns out I really
Yeah.
don't like living with children. They're really selfish.
Yeah. Oh, yeah. I've had all of I'd say all the time, parenting is like 10 extremely frustrating moments for one that is just melts your heart. But medicine is like that too. You have 10 hard visits, and then one is just, this person, you changed their life. And in between all these awful peer-to-peers and things you had to do. So, I think there's a lot of parallels between parenting and medicine, actually.
So I want to just kind of still pull on the thread a little bit about the disparity in women in orthopedics, and then how, we know from studies and know that doctors that treat patients more like them tend to have more cultural competence. Patients tend to do better. And I would assume that this is the same too in orthopedics from a gender perspective, because as you mentioned, I'm not going through menopause. So my focus may be very either limited on that issue if I were in an orthopod's shoes taking care of women, which most fractures of the hip are women, I think is what you said before. So are you seeing, you said there's more women coming into the specialty, more women coming into residency. How do we truly fix this though? Because if it's 252 years before we really start to rectify things, what needs to be done to make this system more stable for women, so there's more of a voice, a focus on women's joint mobility, bones, etc.?
Right. So a couple of things. Yes, I definitely think identifying with your patients or having some shared life experiences is important. When I have a couple of those shared life experiences as like, not just like I have a lot of adolescent patients, and I was an adolescent athlete myself, so I have male and female adolescent patients, but I'm also a mom. So I have like kind of, I, I feel like I have that interaction with the parents and the kids sometimes. But then, my female patients, like, a classic example of something that I think would have been maybe treated or studied or understood differently for a very long time is like adhesive capsulitis or frozen shoulder, which primarily happens in women and was for many, many years just labeled as idiopathic. There are old papers by orthopedic surgeons that refer to people with this as being like histrionic and having mental health problems and things like that. But it is now recognized as essentially a symptom of perimenopause and menopause. And I do a lot of research in this field, and it's probably related to hormonal changes and inflammatory changes and overactivity of fibroblasts and things like that in the shoulder capsule. But if men rarely get adhesive capsulitis or frozen shoulder, and they certainly don't see a spike in it, between the age of 40 and 60, while they're also having hot flashes and night sweats, those connections are just not going to be made because it's not their fault. They just don't live those experiences. Or if they get, they're not getting like, well, I guess men do get urinary incontinence, but they don't get like, general
I do every
menopause. And then, so I think, yes, men don't get that sudden increase in risk of arthritis that women get. Women over 50 are 40% more likely to develop knee arthritis than men. And that's probably also hormonally mitigated, probably by some combination of estrogen and testosterone, actually, research is showing. But, there are things, and women are coming to see surgeons they don't have osteophytes yet. They don't have an abnormality on the MRI, but they're like, my knee is killing me. And they're just like, well, there's nothing wrong, and
I know what's wrong. The
Yeah.
word hysteria comes from the Greek word for uterus, and the idea was that the uterus ran around the body and caused problems in different spots.
Yeah.
So it's just the
Yeah.
uterus running from your shoulder to your knee, and you should
Right.
just go home and relax.
Yeah. Yeah, and there are actual, like, of course, there are people, like, I see people frequently, they just have, like, patellofemoral pain. They really do have, like, normal, there are people that, like, we have to tell them, like, no, everything is reassuring, like, there isn't anything wrong, and there's nothing wrong with being reassuring and telling people that things are okay. But my point is that, yeah, people do have different lived experiences, and if the very small minority of orthopedic surgeons are women, they may not women may be seeing people who maybe are not understanding what they're experiencing, perhaps. And then how do you get, more people in the field? I think just, seeing more people like yourself. There is a growth happening. Like we have a lot of female residents at Duke, and, mentoring them in clinical care, bringing them under your wing and, research if people want to participate in research, mixed teams, like having men and women work together. So, yeah, I mean, I think we try to do all those things, but, and then, here's another thing. So many women don't want to go women for many years stayed away from surgical specialties with concerns for like, well, how can you get married and have a family? And how do you manage that? Like,
That's a systems problem, right?
Right.
That really
And
is.
yeah, here's a good story. When I was a resident, I was just curious. I did take 6 weeks of maternity leave, but my first child was born in September, so the year starts and the residency year starts in July. And the American Board of Orthopedic Surgery had a policy that you could miss 6 weeks in a year, and that was it. And if you missed more than that, you had to repeat the year. And I was just curious. I wasn't planning on taking more than 6 weeks, but I wrote a letter to the American Board of Orthopedic Surgery, and I said, well, what if someone was just randomly due in mid-May, and so they had 6 weeks before July 1, and then they decided to take 6 weeks after July 1. That would be 6 weeks in one year and 6 weeks in another year, and they would get 12 weeks of leave, but they could still advance. But someone who was due June 1st, let's say they had a C-section, needed to take 8 weeks off, they would have to repeat the year? That doesn't make sense. And so I just wrote them a letter with this, how did you come up with your policy? And
I'm sure there's lots of women around the table that had children that really came
and
up with the policy, right?
the head of the American Board of Orthopedic Surgery just wrote me back a letter, and it simply said the American Board of Orthopedic Surgery, in its wisdom, does not have a maternity leave policy. And I should have saved it because it'd be like historical now. It'd be kind of like funny, so that was interesting. And then another time I was doing an away rotation somewhere, at a place that no longer exists, but it was a rotation in pediatrics somewhere else. And the chief of orthopedics there, this is not a Duke professor, this is someone somewhere else, wrote me a letter before my arrival, mailed it to me, and it said, please inform us of the date of your scheduled C-section. Number one, I wasn't having a C-section. Why would I know that? And informing me that I would need to return to work within 14 days of that scheduled C-section. So they needed to know the date of my C-section so that they would know when I would be returning to work.
I would love to see that letter. Oh my gosh.
Yeah. Well,
Wow.
so anyway, I showed it to my residency director, and he was appalled, and no Duke resident ever returned to that site ever again. So, like I said, I had many supportive people who trained me, and I'm, very grateful for them. But you can see what you encounter, and then if someone, so you can see why people are like, oh, is that something I want to? I think
get
things
into,
are
right.
rapidly changing. That would never be something. Someone would never do that now. And likewise, the things I experienced, someone had worse stories 20 years prior. That would never happen.
Yeah, but here's the thing that's so crazy to me. Having gone through, again, like the corporate world, dealt with lots of HR, PR type issues, things like that. These are not legal things. And I think, as medical students and then residents, we come into it. We have no backup, no background. We're dependent upon our residency program directors, many of which have very limited, if any, HR kind of understanding of employment laws, or what are some of the things that they can't do, supervisory responsibilities. I think one of the things that was not expecting to take away from this call is just how backwards medicine can be, and even though it has advanced, but how challenging it can be, that kind of really circles and colors way outside of the lines of what is normal, appropriate employment discussions, interactions.
Yeah.
And that does make it really affects burnout issues, depression, even your ability to continue through certain programs. So it's a big issue that I think that a lot of people come in very ill-equipped, both on the supervisory side and also, of course, on the resident employee side.
When you look back at them in retrospect, you're like, did that actually happen?
Right.
I think this is part of the whole idea that we're expected is not just in the illegal stuff or the sexist stuff or whatever's said to us. When I did my orthopedic rotation, I was expected to be on call Monday until Friday evening, 24 hours that entire week. And so if that's part of it, then you expect everything else that comes with it. And my residency director, I went upstairs because they wouldn't let me do anything other than hold the fingers while they were casting. And so she sent me home, and I'd locked myself. I mean, it was like the worst rotation ever. I'd locked myself in the patient's kitchen and eaten an entire box of ice, like popsicles, because I was so upset at the way I was being treated as like the girl on the team.
Right. One of the reasons I chose to go to Duke for orthopedics was that I did an away rotation there, and I loved it. I mean, I felt like we were having fun in the ER in the middle of the night, working together as a team, like work hard, play hard. And the chief residents, the entire class, they were all guys. I just remember them, like here, going to the OR, helping me get my OR suit, going to total joints, the toga that you wear, and just like, I remember being like, oh, these guys are such good teachers. They're so enthusiastic about teaching. And I loved the energy. Yeah. And we were up late at night, late hours, taking care of people, helping people. And it was like, in a sick way, just fun. And so I had such a positive experience with all these guys who we were all just working hard together. And And like, it was such a wonderful experience. I was like, there was no doubt in my mind that was like where I wanted to train.
I think you're very, very, I mean, I had a good residency experience. I know Laura, we've talked about your residency and fellowship experience for good as well. Like there's of course like periods that were like, okay, that was weird or that was not good. Like your letters, but like,
Yeah.
but you know, for the most part they were good. But I mean, there's definitely, I hear some horror stories out there. Well, I know we only have like 2 minutes left. So,
I want one of those because I want to
Yes,
hear
you
one
take
good
one.
story about Adam as a medical student.
Oh,
Ooh.
yeah. Well, when Adam came to medical school, I thought he was this really conservative guy. He had like gone to Campbell College.
Yeah.
I've, you know, I've read the Bible as a literary piece, but I don't know a lot. I was raised by like I'm like half Jewish. My mom was Protestant. I'm very moral and ethical, but I don't know a lot about religion. There were a lot of religious people in our class, and who I loved our classmates, but I thought Adam was like this really conservative guy, but I kept thinking like he just seems gay. I don't know what he's like.
He's going to be a
like,
church pastor.
he was like, yeah, and he was like kind of sometimes talking about like not finding the right girl, and I think all of us were like thinking the same thing. And again, caveat: I have many gay friends. I love.
She loves the gays. That's what she's saying.
I do. We have so many.
But you
gay
felt
friends,
you
but-
needed to tell Adam that he was
But
not
I,
looking
you
for
know,
any girl.
then I think we were all thinking it, but not saying it. And then one day we were like in the locker room area outside of our like classroom, and he like comes out to us, and everyone was like, "Oh yeah, we all knew that."
It was like,
And
it was
hence
like-
back to the vaginal estrogen confusion.
yeah. It was. I remember it very vividly, and I had said like to Jocelyn, and I think Porter, another one of our colleagues, was there.
Yeah,
and
it was
somebody
me
else,
and
was
Porter and Heather, and we were like, "Oh yeah,
and I was like,
we were
hey,
just
I'm
waiting for
having
you
a
to."
party. And
Yeah.
they're like, why are you having a party at your house? And I'm like, well, it's my coming out party. I'm gay. And they're like, oh yeah, well we know. It was just kind of like, what?
And we were like,
why didn't you tell me? It was,
And we were like, "Yeah."
yeah, but they did come to the party. We had a big party.
Yeah.
So,
Yeah, that's
and so it was good. But okay, my last question to you before we wrap it up is, so what would you say is the most unstable thing that you are seeing now in healthcare? And you may have already mentioned it, but just to reinforce it.
Mm-hmm.
And what is the thing to fix it?
Yeah. So from my perspective, and like I talked about, I don't like to live in a medical silo, but this is what I see a lot. I think musculoskeletal women's health is just a huge opportunity to improve stability in the healthcare system with just a change in the whole way we think about it. Like, why are DEXA scans recommended in 65-year-old women when you're already on average 13 years into menopause? Mm-hmm. You know, if you fall and break a wrist when you're 52, that is when you should be having a DEXA scan. Or, you know, what is your bone density as you enter menopause? Has someone educated you that menopausal hormone therapy is prophylactic against osteoporosis and fractures? Like, are you being given the information to make an informed, decision? Like, we need better distribution of information and, just more informed decision making for women so they can be more proactive about their musculoskeletal health, basically. And there is a turning point. There is like so much information. A lot of it is on social media, which is in many ways good. It gets it out there. But we need to, I think, shift the mindset of healthcare providers. And again, being more proactive, more prophylactic, and less siloed, working across specialties, and that's going to be women's health, urology, cardiology, lifestyle medicine, orthopedic surgery, endocrinology, all
Neurology, all of it.
neurology.
Every part of medicine except the prostate cancer segment.
Yeah. And again, I can think of a million examples. Vitamin D associated with, better bone health, less failure of rotator cuff tears, associated with lesser risk of dementia. Creatine associated with, by, indirectly maintaining muscle mass, perhaps, more bone density. Also cognitive benefits. I mean, there are so many just like minor interventions that cross over, and we need to see people as more whole people. We need to be more prophylactic, more proactive, and less siloed.
Well, I think that's a great way to kind of end things. I just want to remind folks, this is the book. I get it back in the field. Bone and Joint Health Plan. You can get it on Amazon. Jocelyn, it is so good to have you here, and just so excited to see you again and talk with you. I think it's a really important thing that you are doing, and really shifting the focus away from how to treat the disease to how to prevent it. And I think that's a really, really great place to be, and to focus on an area that has not been focused on as much. And that's, of course, on some of the women's health type of issues as well. So, Lara, last words to you.
Thank you for confirming that Adam actually went to medical school.
Yeah.
That was a big question mark. I'm so excited to have met you. Adam has talked you up. What you're doing is great, and I look forward to connecting again soon.
Yeah. Right. Thank you.
Well, thanks everyone for joining. You can catch us on wherever you get your podcasts for Unstable Vitals. Just remember, healthcare is unstable, but worry not. We are too. But there are ways to fix it, and that's why we are talking with you about ways to fix healthcare. So thanks again. Check us out. Make sure you share and follow us. Take care.
Bye, everyone.
Thanks for tuning in to Unstable Vitals. If you enjoyed this episode, make sure to follow us for more unfiltered conversations on the pulse of healthcare. Connect with us on LinkedIn or visit unstablevitals.com to stay in the loop. And don't forget, real change starts with real talk. See you next time.